Okay, continuing on, we're going to go over the coding section. The first section is the ICD-10 CM coding, why the patient is here. In your study guide, the CPT actually comes first. You'll notice that in your study guide, there's also only a few pages for ICD-10. It talks about conventions and things. I'm going into a little bit more detail as far as the ICD-10 CM information for your coding test, because between the medical terminology in the section for them for this particular ICD-10 coding, you are looking at the rules, applying the conventions, applying all the information you're seeing. It's not necessarily specific convention questions per se. It's, are you applying the information, the knowledge that you have to select the correct code? So again, you can use your books, you can use the encoder. It's whatever you want to do. They are pretty straightforward. They're a single sentence in most cases, just like your practice stuff. For the coding certification, it gets a little bit more in depth. And when I go over that, we'll do that. I'll show you the difference and the intricacies between the two. So one of the questions that you're looking at is, it is a universal coding system. So they're used by physicians, insurance payers, other healthcare providers, and billing services to coordinate reimbursement for specific services. Instead of using a description, a long description that will not be the same from one physician or one healthcare provider to the next, we used a standardized code. Different code sets that we have is I-10, CM, it was I-9 before October 2015, HCPCS, CPT, the CDT, which is the dental terminology codes, and the NDCs, which is for the medications. ICD-10, it's used to track illnesses and injuries, conditions that the patient may have. It's the reason for visits. It's your aches, it's your pains, it's your cough, it's your bronchitis. It's the why you're here. It was published by WHO, the World Health Organization, and it's to track morbidity and mortality. So morbidity, the how severe are you going to be ill, and mortality, the what's the risk of death. So we're looking at those types of statistics. It supports medical necessity for procedures and services. It's the diagnosis that we link to those services to show that they are necessary. Just like you don't do a EKG because you have foot pain. That doesn't support medical necessity. Adheres to HIPAA. So we have to, in order to transfer electronic information, it does abide by those HIPAA guidelines. Requires consistent and complete documentation for accuracy. That's the biggest concern, that we thought that as technology evolved, that it would actually improve documentation, where we would have less errors, less minimalistic information that was in place. And in fact, we still continue to see the same things. EHRs ask the same questions of doctors. They get overburdened, they get burned out because they're entering all this information. So what we would think that we would get more documentation, more specific information, and in some cases it actually backfires. So we get even less than if they were just writing a paper note. So we want to make sure it's consistent. So if it changes, we want to see those changes documented within the record. We want to see complete documentation. We want to know, especially being an inpatient. Outpatient versus inpatient is two separate systems, meaning that if they're an inpatient, we should be able to tell if they have a cough, if they have a fever, if they get admitted, and by the time they leave, we should know what those underlying cause for those signs and symptoms are. Whereas in the outpatient, they still may not fully know if it's pneumonia or bronchitis based on several things. And then we do have, for ICD-10, we went from 3 volumes to 2 volumes. Volume 1 is our tabular. That's where we verify our diagnosis, condition, injury. And then our alphabetic index is volume 2. A lot of times you think of them backwards. You think you start in alphabetic index and you end in the tabular. However, volume 1 is the most important volume, and that's where we verify. So we want to make sure that you go all the way to that verification. And then one of the questions that you are going to be asked, whether it's ICD-10, CPT, or HCPCS, and HIPAA especially, is what do they stand for? So those acronyms, you need to make sure that you find them and you highlight them, you mark them, you read your books, however you're going to ensure that you select the correct answer you want to. So ICD-10 is the International Classification of Diseases, Clinical Modification, the 10th revision. Clinical modification is for the United States. Australia has their own clinically modified one, but in most cases they simply use I-10 across the world. So our format, when we're looking at our format, we went from 5 characters to 7. We went from 5 digits to 7 characters. And that was to ensure that we had more specificity. So you see a quick comparison here. The billable codes, we had less than 15,000 in I-9. And so we did see a lot of things that were utilized for the same thing. So regardless if you nicked an artery in your finger or you nicked an artery in your heart when you were doing cardiovascular, it was the same diagnosis code. So we couldn't get a specific. We couldn't show the severity based on that. So when we originally moved up, we went up to about 69, almost 70,000 codes. Now there's more now than was originally, but this is just at a glance on the difference between the two. We had 19 chapters. Now we have 21 chapters. So they did break out the eyes and the ears to give us more specificity again. The code link, we had 3 to 5, and they were actually, we did have a few characters because we had E codes that were external cause codes, and we had V codes, as in violin, for the health status code. So those were the 2 that we actually had alphanumeric for. And then our main codes were just 5 digits. Now we have 3 to 7 characters, so they're all alphanumeric. First character, you can see other characters. You have numeric characters that we have to show we have that it was for I-9. Ability to add code, we had very limited. We either had to delete codes, or if we had new things, we actually just put them under an unspecified or other. We're unrestricted, and we can see that we have multiple codes added each year. And then the detail, again, was limited for I-10. So as you see the format, we have our alphabetic character in the beginning, everything except U. And again, that's one of those questions that could be true or false. It could be just a question they ask. We have numeric for our category. So the letter is going to tell us what system it has to do with. So like obstetric starts with O, prenatal is P, gastrointestinal is G codes. So then we have our etiology, our site, laterality, and other is the next 3 characters after the decimal, and they could be numeric and alpha because we are except U again, because we do have those placeholders. And then the extension, we have those extensions for our injuries and our fractures, so we can get more specific. Conventions that they focus on in the CMRS is the includes notes, the inclusion terms, exclude one, exclude two, as well as the additional characters. So these are the ones that they're going to ask you questions surrounding these type of notes and conventions. Includes, we see those includes notes at the beginning of the chapter, so it applies to the entire chapter. Think about the prenatal codes at the notes at the beginning, talking about the what's included as far as complications, the sequencing notes, the trimester notes. And then you have it for a code range, so it could be for several categories, and then under that we're getting one note instead of placing that several times, because again, the more we add, the bigger the book gets. And then we could have some inclusion notes just under the character codes. Inclusion terms, those are going to be your other terms that conditions, synonyms that can be listed to tell you that this is the correct code that you've located. However, they're not a comprehensive, all-inclusive list for each one of the codes, so you do go by the alphabetic index. If it sends you to that code, that's the code we use, and that's known as a default code. But you could write it in if you're going to use that code, that condition a lot. You might want to go ahead and add that to your tabular. Excludes one, this is where we normally highlight pink, and that's to tell you you're not coded here. So we cannot code the one that says excludes one with the condition you're in. You code to the one that is the most specific and is the highest severity of the two. Excludes two means that if we have documentation to support that condition, we can assign it in addition because it's not included in that code description, and we normally highlight those orange. Code to the highest specificity. So you have 2 colors of 7th characters within your ICD-10 book. That's one of the things when we were in coding 1 that you had difficulties with. Notice that when we've had different quizzes and things in coding, that's one of the areas that you get off on. The maroon 7th character tells us that you want to continue down under that character, that category code, until you get to the most specific character, meaning that it goes all the way to 7 characters. Whereas the blue, you'll notice it has the check mark as well as the X, meaning that there's a placeholder, and in that instance there is the box that has to do with the 7th character. So on those, you can do it one of 2 ways. You should have marked it. You can either mark the blue and say you need to do the X and see the note box, or just know that you do need to make sure that if it says 7th character out beside it, that code should have 7 characters within it. When you're doing your certification exam, you want to make sure that your code matches up. They could give you the wrong code. They could give you the wrong amount of characters. So just pay close attention to the detail when it comes to that. As far as what you should and should not assign, when it comes to signs and symptoms, if we don't have a definitive diagnosis, meaning the patient presents with cough and congestion, and that's all it said, and they run tests, they did lab work as well as maybe a chest x-ray, and at the end, the doctor simply said that the patient had a cough. You would code the signs and symptoms and nothing else, because we do not have the definitive diagnosis as the underlying cause of those signs and symptoms. You do not want to assign sign and symptom codes that are integral to that definitive diagnosis. So, for example, If the doctor says the patient comes in with a fever, cough, and congestion, and at the end he says the symptoms are related to the acute bronchitis, he's linked every one of those symptoms to that acute bronchitis. Pay close attention to the wording and the verbiage that the doctor may utilize, because he could say the cough and the congestion is related to the acute bronchitis and not link the fever. So in that instance, we would want to pick up the fever and then the acute bronchitis. And then do not assign signs and symptoms that aren't integral to that disease process. So that's what I just said as far as the fever. If it's not linked to that definitive diagnosis, we want to pick those up. And then another thing that wasn't as specific when they were discussing our testing for the CMRS was the most severe, the way in which we sequence our diagnosis. You want to make sure you sequence the most severe or the acute reason for presenting to the visit. So we want to link, we're going to use these diagnoses to link to procedures, services, supplies that support medical necessity. And you link in order of importance. So it says A, B, C, D. Where that comes from, when we look at the CMS 1500 claims form, you're going to notice that for the updated new claims form, we use A through J for our diagnosis numbering, whereas the one prior for I-9 was 1 through 4. So that's the difference. We're going to use A through B. Now for everything, for all supplies, procedures, anything other than the evaluation and management code, you're only going to link one diagnosis to that procedure. The reason for that, when you link more than one, even though you may, for example, have a laceration to your finger and a laceration to your hand, it's a simple laceration, and we had to combine those sizes to get that CPT code, you would actually, that CPT code would be for both of those. However, it could, for the carrier, actually cause a denial. So in order to prevent that, you would pick the most severe of the two lacerations to link. But just make sure that whichever carrier you are billing for, you follow those rules. So if they say that they want both diagnoses linked, you would link both. But if they only want one, pick the most severe. There are some hyperlinks again. So ICD-10 basics for practices, ICD-10 facts and myths. Within your study guide, if you click on them, they'll actually take you to those areas. I'm not going to click on them now, but within there, it will take you to the CMS or to a newsletter, a article that the AMBA has actually linked and says that that's where you can get information. That could be where some of the test questions are taken from. So if you come across a question that you're like, I don't know if it looks like it's a fact or a myth, or it may be a best practice scenario question, you can click on those hyperlinks within your study guide, and that will help you. Now, what's highlighted in yellow here, as far as it's not recommended that billers provide coding services to clients unless they are certified in coding. That is a true-false question. That is stated in multiple areas. You can bill, but you can't code. The reason for that is billers get a very limited view on coding, and you know that based on the two classes that y'all are taking. We simply focus on how do you use a code book, how can you find things, not necessarily all the intricacies of coding. So If you do not get that coding certificate, you need to focus mainly on billing, maybe looking at denials, things of that nature, but do get a coding certificate to a certification to show that you understand the rules of coding. All right, next is our CPT and HCPCS. This is the majority of what they look at is they focus on CPT. CPT, they do have HCPCS codes as far as the supplies and things, and you will look those up. But CPT is the main answer here. So if you have true false questions, if you have things, it's going to be those type of things are going to be listed, some in the study guide, but a lot are in your CPT or your HCPCS book. So the things that I've mentioned that you need to highlight or review, those are the things that you're going to be asked. You need to review those guidelines. So if it says, can you code this? You go to your guidelines and you read your guidelines before you answer the question. Again, once you submit this and it grades it, you can't go back, but you can always make changes up till you submit it. So the layout here, you have your CPT, which is level 1, and you have your HCPCS, which is a level 2. So they're your national codes. Your HCPCS was developed by Medicare for Medicare and Medicaid patients, whereas CPT was developed by the AMA, and it was to show the procedures and supplies and services that the physicians were using. So it is updated annually and it goes into effect January 1st, whereas ICD-10 is updated annually, but it goes into effect October 1st. It does have, CPT has 6 sections. It's got E&M, it's got anesthesia, surgery, radiology, path and lab, and the medicine section. Now you also have multiple appendices, you have illustrations, depending on the publisher, depends on the extra information that you get within the book. So CPT is the terminology just used to describe that particular procedure and services performed and provided by the healthcare professionals. Again, you want to make sure that you either put that in your CPT book, you highlight it in your study guide, because that will be a question. Oops, sorry. Okay. HCPCS are your supplemental codes to describe supplies, drugs, services performed and provided by healthcare and non-healthcare providers. So you're looking at other services like case management, therapy services. And then your HCPCS CPT, it controls reimbursement for your outpatient. The reason I put outpatient, now know that it controls reimbursement as far as your study guide goes. It says reimbursement. When you're out in the real world, we're looking at the outpatient side of things. Inpatient goes by DRGs, which are driven by diagnosis, and depending on, do we have complications, do we have major or minor complications and comorbidities, what's going to increase the risk and the severity, as well as did they have other procedures that fall under those. But we're looking at outpatient for HCPCS and CPT. Okay, so 6 rules for coders, and this is in your study guides. You see that it just says coders. So we had the coder consults the patient health documentation that you have. We open the index and find the services and diagnosis. So your CPT, your HCPCS, and your IS-10. You don't code directly from the index. Whether you know that that's a complete code or not, you want to verify in your tabular. You evaluate the full description in your tabular, whether it be HCPCS, I-10, or CPT. You review the chart documentation in case you need to add modifiers. So the modifiers are what's appended to our HCPCS, or not our HCPCS, our CPT codes. And then we want to send a clean claim to the carrier for reimbursement. So if you have a clean claim, you're going to get your reimbursement faster and fully. Whereas if you don't, you send one, you could prolong reimbursement or even get a claim denied or rejected. So indexing your main terms. You're going to look at procedures, services, your organ, your anatomic site, your conditions, your synonyms, your eponyms, and your abbreviations. And in the order that it's listed in before your alphabetic index on your CPT, that's where you start. So you start with your procedure, you start with your service type. If it's not listed there, then you go to your organ, your anatomic site, your condition, your synonyms, and so forth. This is different than I-10. I-10, we look at the condition, the illness, the sign, the symptom, abbreviations. We can look at eponyms and acronyms. You never look at the adjectives such as acute or chronic, and you never look at the anatomical site or organ. Types of codes that we see in CPT. We have our standalone and our parent indented codes. So our standalone codes is the code that's just there standing alone. They can be a single code where you assign that code. They can be add-on codes. So it's a code that doesn't indent. It just stands alone. We add that. Your parent code holds the main code description, and it begins with that capital letter to the semicolon, and that's the main code description that will follow down to the indented codes. The indented code provides the additional information. What's different between the parent code and the indented code? So the example here is the 20,600 is the arthrocentesis, aspiration, and or injection is the main code description. And this particular code deals with the small bursa or joint, whereas the 20,605 is indented, and it is an arthrocentesis, aspiration, and or injection to the intermediate joint or bursa. So the indented code is not capitalized. Other key facts that we have. So we have unlisted procedure codes. As far as if we don't have a specific code that meets the code description of given, we're going to use that unlisted code description. Symbols. So we have multiple symbols, and they're in the front, located in the front of your CPT to give you a definition of each one of the symbols, and they are listed across the bottom throughout your CPT book, so you can access them quite quickly, reference them. So we do see that contains new and revised text. So the information that is between those two triangles that are facing each other, that's what is changed from one year to the next. The filled in bullet is a new code. We have a revised code. We have identifies codes that have been resequenced, so they can come way before the code is supposed to be listed or after. So just make sure that you pay close attention to those. With our professional versus technical, those are questions that you're going to have on your certification. Professional meaning that's going to be used the 26. Technical is the TC. When we're looking at what's professional versus what's technical, the professional does the interpretation and written report. It's the doctor that is reviewing that information, whereas the technical component is where the technology is housed. It's the technician that may be like the radiology tech that may be doing the procedure or service, the materials that are used, the equipment, the film, the office or facility space. So anything that's going to take to run that. The next thing is new versus established patient. So for the CMRS, you do look at the evaluation and management. It doesn't get into a lot of detail and you don't have to code a lot. What it's going to show you is this is a new patient, it's a new office patient, it's an established patient. It's going to tell you that straight out. What is different between the two is a new patient hasn't been seen within 3 years. So if the last time you went to the doctor was 3 years ago, and he has several doctors, or she does, within the practice, and you haven't seen anyone within that practice or that group, then it's a new patient. So when you go back, you'll actually be a brand new patient. So they have to do more documentation to make sure nothing's changed with you. Whereas an established patient, you've seen either that physician or someone within that group within the 3 years. So it's, say for example, you go to the cardiologist, well, your main cardiologist is the doctor, but most of the time you're seen by the PA or the nurse practitioner that also sees patient. You would still be an established patient because you're seen within that same group. In your CPT, there's actually on page 5 where your evaluation and management begins in those guidelines, it has a flow chart that you can review. So other key facts that's good to keep in mind is patients are considered outpatient until admitted as an inpatient to the facility. So when you're reading your documentation, things that you may look for is the patient was admitted, they're in ICU, they've moved to the floor. So those are some things when you're looking at how do you tell. So you could see for new versus established, this is the first time I'm seeing the patient. The patient came in to be consulted to receive a second opinion. I seen this patient last week, or this patient is returning. That would tell you that they've been here before. All right, modifiers. So with our modifiers, you have modifiers that are numeric, alpha, and alphanumeric, depending on what you're looking at. So the purpose of our modifiers is to alter the code descriptors without actually changing the code entirely. So you don't have to change it and you don't have to create a new one. We just modify it based on, was it increased? Was it reduced? Are we repeating something? It lets the carrier know that there's something different about the code than what is normally done. We have the reason modifiers are used. They're appended for unbundling. You have your unbundling modifiers. They are there to say if they're reduced, if we're repeating things. So you want to look on Appendix A because you will have questions that are specific to modifiers. It starts on page 809 in your CPT book. As you're going through that, you'll want to read the code descriptions to select the correct modifier. So when you're deciding which modifiers come first, when we're looking at it, the modifiers that impact payment come before informational. But when we're looking at, for example, we have those separate procedures. So we're showing that there is a true reason that this is separate. We're going to unbundle that modifier 59. So on our procedure, if we are unbundling that, showing that we have a distinct reason that we're doing this procedure, then we would put that one first. And then the next would be other payment modifiers to prevent denial. So if we repeated it, if we did anything like that, you do have 4 places on the CMS 1500 to put modifiers. So you can use more than 4, but you want to put those on there. Then after that, you would put informational. So was it the left? Was it the right? Things of that nature. Things that just tell us a little bit that's going to change, that's not going to impact reimbursement. So then we would do if they reduce reimbursement, if they reduce for the payer. Otherwise, the payer may reduce it. So you want to add those. If you're going to reduce the amount, you want to make sure that you don't put the modifier on there. The reason the payer would go ahead and reduce it. However, a lot of times you don't pre-reduce it. You put the modifier on that and they reduce those services. And same thing with increasing. You want to increase that reimbursement so it does show that that's been done. Our anesthesia modifiers, they are in the anesthesia section guidelines. Again, you're going to pay attention to, was it a normal patient? Were they over a certain age? Do they have a systemic condition that is under control, not under control? And for this particular CMRS, you're not going to have to worry about those code amounts because that's not specific to billing for this particular test. Our HCPCS modifiers, they're alphanumeric. So like you have your TCs for your technical components, your left. You also have E1 for your eyelid. So those are different modifiers. Your global period, you have questions that have to do with global periods. You want to see your HCPCS in the back under the correct coding guidelines. You do have your global period is listed, what's included. But what's included, and you can make a note in your CPT if you want to, it includes your pre-op, the day before, a surgeon, if they're going to do a consult to make sure you need it, that's not included here. Your H&P, your intraoperative services, what's integral to the surgery, complications that do not require. So we can have complications that the patient sees, like they do become anemic, but they didn't have to go back to the operating room. So those would be considered part of the global period. Reoperations, when there's no CPT, if there is a CPT code that is for reoperation of any sort, then we are going to bill that. We're going to code that separately. And then pre-op, 11 to 90 days. The reason I said 11 is because 0 to 10 is minor surgery and they don't fall within a global period. Then what you see is like suture removals. If you go back to see the same doctor, it's gonna, when they remove those sutures, are gonna fall there. Immunosuppressive therapy for organ transplant is not included in the surgery. So if they're having to do immunotherapy, suppressive therapy, so they can do that, that's not going to be included. You're going to code that separately. Complications or problems unrelated to the surgery. The diagnosis, you're going to need a reason. It's going to be unrelated to that reason the surgery was initially performed. And it's also going to require a different diagnosis to support those other services. If we have multiple procedures performed on the same day and they're major procedures, so again, 90-day global period, the major procedure listed first, you're not going to append any kind of modifier unless there's one that's the 22 that increase the service, anything of that nature. The lesser procedures that are performed at the same time as that one was that falls within that 90 days, you're going to use that 51. It's going to show multiple modifiers. Multiple procedures were completed. Now keep in mind, if it is one that is that separate procedure, and then we need to show that it actually was distinct of this major procedure, we would use 59, not 51. Okay, procedure tips. So we've got biopsies, closures, applications or removal of devices, arthroscopic procedures, and multiple anatomic sites. Biopsies, you want to keep in mind that a lot of times these are just routine to the procedures, so we wouldn't code those separate. If they strictly come in for a biopsy, then we're going to code that. But anytime that they remove tissue, they're going to send it to pathology. You'll see that in a note. That doesn't necessarily mean it's a biopsy. It just means they're doing a tissue. They're looking at the tissue to determine the specifics. Closures. For closures, most simple closures are included in other procedures. For some procedures, intermediate may be included, so you want to make sure that you pay close attention to the directions and the notes within the charts. Do not simply go by the name of the procedure. You want to make sure that you're reading the note of the procedure, because a lot of times you will see that a doctor says it was an intermediate or complex procedure closure, and in actuality it was just a simple. And at the same time they'll say simple, but they went in and they cleaned foreign body out, they did extensive cleaning, they did a dual layer closure, so that would make it intermediate, but they are calling it simple because it's something that they routinely do, so there wasn't anything out of the ordinary. So again, make sure you read the note and assign it appropriately. Do read those code descriptions at the beginning of the repair section. Application removal of cast traction devices are included in the restorative treatment. So if the same doctor that placed the cast removes it, or placed the traction device removes it, it's included. If a different doctor does it, say they came to the emergency room, they placed the cast here, but then they went to their primary care doctor and there was a reason the cast broke, they were having other issues with it, and they removed it and replaced it, we would code it because it was done by someone else. Arthroscopic procedures includes a diagnostic arthroscopic procedure performed during the same procedure. So if we had one did at a different setting, you could assign both the diagnostic and the therapeutic. And again, multiple anatomic sites. You're going to code specific separate site and append modifier 59. You're looking at, if we have multiple closures, say they did a closure on your hands, a simple closure on your hands and a simple closure on your forehead, the first one would not have a modifier attached and the second would have modifier 59 attached. Okay. HCPCS. With our HCPCS, it's Healthcare Procedure Coding System. It was developed in 1983 by CMS, and it's mandated by Medicare and Medicaid carriers. It's for physician and non-physician services supplies. It's primarily for Medicare, but we are seeing almost all carriers utilize HCPCS codes because they want those specific codes. to better bill and reimburse for services and track. It's used to bill services procedures not defined in CPT, so such as your ambulance, your audiology, your physical therapy, speech pathology, drugs, and our durable medical equipment. So with our HCPCS and CPT, when we're looking at drug administration, it's going to require two codes. You're going to have one for CPT administration, such as the route. So was it intravenous? Was it a push? Was it an infusion over 16 minutes? Was it IM? Was it subcutaneous? Was it a vaccine? So we're going to have that administration code. And then we want to know what drug, and that's the HCPCS. The HCPCS is our J codes. So not only do we have to pick the correct J code for the route that it was administered, we need to make sure that we're looking for the quantity that needs to be attached as well. 99070, it's a catch-all supply code that we used to place on it to catch the surgical trays and the bandages and all of those things. However, most carriers don't pay for that. They want specific HCPCS codes in order to reimburse appropriately. Doesn't necessarily mean you're going to be reimbursed. It just means that they're going to see, they can track the products and supplies that you're using. Additional coding tips, you want to describe the supplies, materials, services of the medical professionals. It's mandatory for Medicare and many Medicaid carriers. You do want to pay attention to, there are some codes that you cannot bill for Medicare and some that are strictly Medicare and Medicaid carrier codes. They are 5-digit, they're alphanumeric, and they do have alpha or alphanumeric modifiers. And they are going to be revised annually with the new additions available January 1st. Okay, so I'm going to stop here. And the next section, we're going to go over EDI transactions and clearing houses.